Painless jaundice with a palpable gallbladder. It is a Courvoisier's law. So let's discuss this common surgical case today. So we have a 58-year-old chronic alcoholic and a smoker male who presented to us with a 3-month history of painless and progressive jaundice that is very deep and currently present on his palm and soles also. And on examination, there is palpable gallbladder in the right upper quadrant region. Patient also has complaints of dark urine and pale colored stool. He also has a history of significant weight loss and early satiety. And on examination, there is this deep icterus and a palpable gallbladder. There is hepatomegaly and scratch marks present over the abdomen. And on lab evaluation, there is increased direct bilirubin, increased ALP, and increase in CA19.9. On USG and CT scan, there is dilated CBD. So, what do you think the diagnosis of this case is? Is it a case of cholelithiasis, choledocholithiasis? Is it hilar cholangiocarcinoma, or is it a case of periampullary carcinoma? Yes, you are right. This is a case of periampullary carcinoma, and this basically includes 4 different cancers that are present around the ampulla. One is adenocarcinoma of head of pancreas. Next one is ampullary variant of periampullary carcinoma. Next is distal CBD, and the fourth one is duodenal adenocarcinoma. So these are 4 different malignancies that are included in this periampullary carcinoma. And the very important, very short question for your Viva and surgery exams is Courvoisier's law. And this law basically means that if a patient presents to us with progressive painless jaundice and a palpable gallbladder, then this is a case of malignancy. And stone disease basically cause atrophy of gallbladder. So gallbladder is not palpable in stone disease. For the diagnosis part, with this clinical history, we are able to suspect this diagnosis. Then on USG, we can get dilated duct, and there can be some evidence of mass in the periampullary region. On MRCP, we can get a double duct sign, and on CT scan, we can appreciate the vascular anatomy. Like, is the malignancy resectable, borderline resectable, or non-resectable? And depending on that, further management will be planned. If the disease is resectable, then Whipple's procedure, in which we resect the distal CBD, distal part of stomach, duodenum, and some part of jejunum along with head of pancreas is resected. Then reconstruction is done. And in cases of borderline resectable disease, we go for neoadjuvant chemotherapy, which is gemcitabine based. And in metastatic disease and in cases of non-resectable cancers, we also go for palliative procedures like ERCP stenting of CBD or percutaneous transhepatic biliary drainage, or we can go for gastrojejunostomy in case of gastric outlet obstruction. So this Courvoisier's law is very important, very short surgery Viva and exam question. So do save it, do read it, and do follow diagnose it for more such interesting cases. Thank you.